Right, you can start the recording now. We can do the live stream.
Yeah, and
Yes,
you can.
we are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for 54th episode of AMOGS Emergency Obstetrics Committee with Surat, Baroda, Rajkot, Aanand, Nadiyad, Bhuj, Valsad, and Porbandar OBGYN societies. So I wish all the doctors a very happy Doctors' Day. And it's my privilege to introduce the convener of today's webinar, Dr. Archana Dwivedi ma'am. Ma'am is the chairperson of Midlife Management Committee, FOXY, for 24 to
I think
26.
we can cut it short. Thank you for the introduction.
I welcome you, ma'am.
Yeah.
And it's my honor to introduce the coordinator of today's webinar, Dr. Sarfraz Qazi sir. Sir is the president of Himmat Nagar OBGYN Society from 24 to 26 and also local joint secretary of SOGOG 24 to 25. I welcome sir and I hand over the session to the convener.
Yeah, thank you so much, Saiti, for the kind introduction of both of us. It gives me immense pleasure to invite the stalwarts. I can see everybody in front of my screen. We invite you, sir, madam, everybody, on the 54th AMOGS Emergency Obstetric Committee webinar, which is in association with Surat, Baroda, Rajkot, Aanand, Nadiyad, Bhuj, and Valsad and Porbandar Society, our own Gujarat team. It gives me immense pleasure to see Dr. Pankaj Desai sir, Dr. Rohit Bhatt sir as our chief guest for today's this thing, and guest of honor Dr. Prakash Bhatt sir and Dr. Nimesh Shalat sir. AMOGS team, Dr. Kiran Koti sir, who's the president, Dr. Vipin Pandit sir, who's the secretary general, Dr. Rajendra Pardesi sir, immediate past president, and Dr. Madhuri, a dear friend who is the treasurer right now. So along with this, it gives me an honor to be associated with this team since last few years, learning experience, and also Dr. Sneha madam is here. Can we have her CV, please? Saiti?
Yes, ma'am.
Before we go for the prayers, we would like to
Just a second.
Today we have got very important topics. I think cesarean section is something we do, every obstetrician, hardcore obstetrician does day in, day out. But doing a difficult CS and learning the masters over here, as Dr. Desai sir is going to talk about it, would be a learning experience to us. And VT during pregnancy with Dr. Uday Thanawala sir, and then brainstorming panel, which will be led by Dr. Sneha Bhuyar madam, who is has the best wishes from Gujarat from all of us. And we were discussing just now, as Dr. Desai sir had a spiritual enlightening also on this subject. And with presence of eminent faculties, we wish you best, Neha ma'am, for this future endeavor. Just to make it a little more vibrant and visible to all of us, I invite Dr. Sneha ma'am officially to start the inauguration process by inviting our chief guest and guest of honor. She has given many talks and publications. She was organizing chairperson for Criticare Nagpur, Zonal AMOGS, Lactacon Pune, BreastCon Pune. She has won accolades and awards as a National Faculty HPV Master Trainer, National Individual Award by FOXY 2008, Anandi Bai Joshi Award by Government of Maharashtra in 2005. She was also National Adolescent Trainer, FOXY President Appreciation.
Thank you.
Yeah, thank you, ma'am. So many things in her CV, and it gives me a proud privilege to invite madam to take it further. And nonetheless, Dr. Kazi, who has been a backbone to me, who has been always very supportive, I welcome you all also. And all the dignitaries from Gujarat over here, Dr. Quresha is here with us, Dr. Jagruti ma'am is here. And it gives us a good time, academic time coming forward, not standing in between. Over to you, Sneha ma'am.
Yeah. Thank you so much, Dr. Archana, for that kind introduction. A very good evening to one and all. At the outset, a very happy Doctor's Day to all of you. My respect and regards to all the seniors here. I would like Dr. Archana has already welcomed all of you, so I would not like to repeat the names, and I would just welcome all of you in common. I just take this opportunity to introduce and invite our chief guest for today's program, Dr. Rohit Bhatt sir. We are very Blessed and privileged to have you, sir, as the chief guest. All of you know that sir is the past president of Foxy, Nachi, and Isopub, and he is the recipient of a Lifetime Achievement Award from Foxy, Nachi, and Harvard University. Is the past vice president of AOFOC, the BCRI awardee as eminent teacher, and lots of awards and accolades to his credit. We are really blessed to have you, sir, as chief guest. We are eagerly waiting to listen to your words of wisdom. Over to you, Rohit, sir.
Am I audible? Can you hear
Yes.
me?
Yes, sir. Yes.
Thank you very much, Neha. Before I start, I must wish you good luck for your new assignment that you are going to have. I congratulate all the organizers who have organized this particular workshop. It's a very interesting subject, very important, because emergency obstetrics, if it's not handled in time, might result in mortality or morbidity. And therefore, I think that emergency obstetrics must be taught right from undergraduate days to the students, and certainly to all postgraduates, how to deal with emergency and sometimes how to anticipate. It's not always that you can anticipate all emergencies. Sometimes it comes suddenly, like a bolt from the blue. But you can anticipate, like the grand multipara, all these things might happen, placenta previa. We must know what complications can arise. And there are brilliant speakers. I know Pankaj has to wait for his dinner with his family at 6 o'clock. So I would not take longer time, but I wish program a great success. Thank you very much.
Thank you so much, sir, for all your blessings and guidance to all of you. With this, I just request Dr. Sahiti to please display Sir's CV, Dr. Pankaj Desai, sir, who is also the chief guest for today's program. And sir is, of course, the past president of Foxy. And we know sir by, as a multi-talented, multitasking personality who is having, his own opinion, who is, he's a trendsetter, I would say, rather than a follower. So we would like to follow you, sir. Of course, you have so many credentials here. Consultant obstetrician gynecologist from Janani Maternity Hospital, Baroda, and former dean, associate professor, unit head, and so many positions you have hold, sir. I can see, highly decorated CV, and of course, such a illustrious personality. We would rather prefer to listen to your words of wisdom, sir. Over to you, sir, Pankaj Desai.
Shall I start by lecture on peripartum care?
Yeah, you can just pick a few words, sir.
My good wishes, sir has spoken, and
Okay.
I have got you have given me kindly full 20 minutes.
Yeah.
You didn't give that privilege to even Rohit Bhatt, sir.
Sir.
So I will use that rather than going on speaking and speaking.
Okay.
Wish you all the best, and may God always be with you. God bless you.
Sir, thank you, sir. Thank you so much.
So, Dr. Udit Hanawala sir has joined, ma'am.
Yes, sir. Welcome, Dr. Uday. So we would just like to go ahead with the blessings and precious words from our guest of honor. I hope Dr. Prakash Bhatt sir has joined. Sir
No,
just
ma'am.
to me, but he will join. Maybe we can have Dr. Nimish Selat sir's the speech first. So, sir, Dr. Nimish Selat, I'm sure everybody knows him. It's a very prominent personality in ESR. And sir is a renowned gynecologist, microsurgeon, director, over 44 years of experience. Of course, past vice president of Foxy, and recipient of over 21 national and international awards. I was a gold medalist, and of course, lots and lots of professional experience in, as we can see it here in the CV, but definitely a very warm-hearted personality and genuine at heart. We would like to welcome you, sir, and have your words of wisdom. Over to you, Dr. Nimish, sir.
Thank you, Dr. Sneha. It's a great pleasure to see you in this particular webinar with so many other luminaries who are very warm colleagues and mentors as well, and senior teachers. And I'm very happy that this webinar has been organized today, considering the various aspects of obstetrics and gynecology, particularly obstetrics. And my dear friend Pankaj Desai is also going to talk today. But at the same time, I really wish you a very, very positive, results of your efforts to contest this Foxy elections this time as a vice president candidate. And we all will be together. We are planning a very fantastic and a very great event at Surat Obstetrics and Gynecological Society in 2027 January for holding the All India Congress of Obstetrics and Gynecology of FOXY, for which of which I am the organizing chair, and Dr. Prakash Bhatt is the scientific chair, and we are planning to give a lot of positivity as well as variation and the best of hospitality with the best food ever possible for all the delegates. So looking forward to everyone at the same time, giving you all the best wishes for the future as well as for the coming elections. Thank you, dear.
Thank you so much. Thank you, sir. And may I just utilize this opportunity to welcome each and everyone. Yes, Archana?
Dr. Prakash Bhatt sir has joined, so we can have a word.
Yeah. So we welcome you, sir. And of course, we are eager to listen to your precious words. We know, sir, as the past president of Surat Obsgani Society, when the society received Best Society Award, and sir was the vice president of FOXY 2005. I had an opportunity to meet Prakash Bhatt sir personally on many occasions, and of course, a very kind-hearted personality and guiding force. So we'd like to listen to your precious words, sir. Please do bless us.
Thank you, madam, very much. The words are not that precious as you expect them to be, but I can at least wish the program a success, and I wish success to you also in your coming endeavor. And I'm so happy that I'm looking at my friend Pankaj Bhai Desai here. I just texted him that I have just returned. And of course, Nimish Bhai is already there, and he has talked a lot about the coming events. All the best, madam, from my end. And if you permit me, I would like to request your leave. I'm not feeling very well.
Definitely, sir. I know, sir.
Thank you very much. Thank you.
You've already talked.
Yes. I will ring you up today. Today or tomorrow.
Bye.
I'll ring you up today.
Okay.
Sir, thank you so much. And with this, I also would like to welcome all the respected faculties here. I can see Dr. Gopal Hirani sir just joined, Dr. Jigna Ganatra, the president of Rajkot, and Dr. Jagruti, a dear friend from Baroda, past president of Baroda. Also the other chairpersons, Dr. Kokila Desai, the president of Surat Society, Dr. Deepa Rakesh Pitre, the president of Baroda, and also Dr. Amita Shah from Baroda, who is the expert for the panel discussion, and all my dear friends, esteemed panelists. I would like to welcome all the presidents and secretaries of all the societies, Surat, Baroda, Rajkot, Aanand, Nadiyad, Bhuj, Valsad, and of course the Porbandar. So with this, with the blessings of God, Lord Almighty, and the blessings of seniors, we would like to go ahead with the academic session. I would like to thank Dr. Archana Dwivedi, the convener, and Dr. Sarfraz, the coordinator for this program. Thank you so much. We can go ahead with the academic session. Over to you, Archana and Sarfraz.
Thank you so much, madam. Thank you, dignitaries, for joining us for the inaugural ceremony. I hand over the baton to Dr. Kazi now to take the academics forward from here for the first session. Over to you, Dr. Kazi. Okay, I think he has Kazi, can you hear? Okay, then I'll do.
Hello.
Yeah, please go ahead.
Yeah. So our first talk is on difficult cesarean section by one of the best orator I have here.
That is not my topic. It was peripartum cardiomyopathy.
Peripartum cardiomyopathy only. Saiti, I think you.
Okay, till Saiti has corrected the topic PPCM. PPCM.
The topic PPCM only. Yeah. Maybe here it is displayed wrong.
No problem. Yeah. No, as a teacher, if you want, I can talk on that topic also.
On PPCM. Whole obstetric, anything, anytime, sir. You are the best orator.
I'll cover PPCM
yes,
for some reasons. There is something new which has come there.
For this talk, our chairperson are Dr. Gopal Hirani, sir, who is right now lastly, he was the past president of SOGO, and he is working since last 35 years and the best laparoscopic surgeon in the area of the Bhuj I have seen. He has completed his postgraduate from MPSA Medical College, Jamnagar, and founder of the Hirani Hospital, which is established in 1985, so long year back. And his area of interest is laparoscopy and infertility. Apart from the hospital in Bhuj and Kutch, he provides complete treatment related to obstetrics and gynecology. And his hospital is committed for the affordable healthcare services in Bhuj area, which is the far away area of the Gujarat. Our next chairperson is Dr. Jigna Ganatra ma'am. Working since last 15 years at NM Virani Wokad. Her area of interest is high risk pregnancy. And right now he is the president of the Rajkot Society. Next. Everybody knows Dr. Jagruti ma'am, past president of the Surat. Right now president of the Menopause Society from 2024 to 2026. She was the master trainer of the Dhira program under the leadership of Santa ma'am. And Foxy recognized laparoscopy centers. She is running Dr. Paul's Institute at Kochi. She has taken the training. Ma'am, you are going to introduce Dr. Pankaj sir.
Okay. Yes. So, good evening, everyone. And a big thank you, Dr. Sneha Bhuyan ma'am, for providing this opportunity. So, Dr. Pankaj, he already said that we were classmates, right from preparatory science to finishing of our MD. He's a great academician, teacher, scientific researcher, inspiring public speaker, and has given a lots of motivational speeches also. He is a consultant at Janani Maternity Hospital, Baroda, was former dean and associate professor of Baroda Medical College. He has received the Lifetime Achievement Award from Foxy. His list is very big. And Pankaj, I'm sure you won't mind if I cut it short. Right?
Please do it.
So, so welcome. The stage is all yours. Welcome for your talk.
Thank you. I'm sharing the screen. Can you all see, I think?
Yes, yes.
Okay.
Make it full screen, sir.
We'll make it.
Yes, sir. Done.
Okay. Can you see the slide?
Yes, sir.
Yeah. Not the content, the slide.
Yeah.
Okay. As usual, we will start with a prayer. But here there are no animations because this medium is not good for animations. So we'll start with a prayer. We reverently pray for eternal harmony in the universe. May the weather be seasonable. May the harvest be fruitful. May countries exist in harmony. And may all people enjoy happiness. Dr. Jagruti, thank you very much. Knowing her since the days when people used to call her Minu, for us she is still Minu, and she thought that we may have forgotten her name. For below that CV, there should have been a line that a friend for Dr. Jagruti Desai. That would have been enough in that CV.
Okay.
Friends, the topic I was told today was PPCM, and then suddenly certain things changed. So it's like an unstable life. Most of the times it was vertex, but suddenly it turned into breach. Sarfraz is known for that. And now it thankfully, once again, Sneha madam has converted it back to vertex. So it will start with that topic. And that topic can be compared to what has happened a few days or few weeks before, which is very gory, the Pahalgam attack. The topic, and if and when it occurs to any of our patients or to the patient herself, the condition is chilling, terrorizing, scary, and we wish it would never have happened. After pulmonary embolism, if the next thing which I would like to dread is peripartum cardiomyopathy. The pregnancy in these cases is going fine, no premonitory symptoms. It reaches nearly its end, and suddenly there is a U-turn, sudden turn. It is a rare idiopathic cardiomyopathy. And we had a genius teacher, Jagruti will remember, Dr. Bhatt sir will also remember, Dr. A.M. Thakkar, who used to tell that idiopathic is for idiots. It has no explanations, and that is where we get beaten up the most. It primarily arises in the last month of pregnancy or the early postpartum period, and sometimes may develop earlier in pregnancy or beyond 5 months. I am coming to that. But your majority concentration, 98% cases will come here. We as academicians are known to needle. કશું સીધું નહીં રવા દઈએ, અમે એને ડીંગલા કર્યા જ કરીએ. This is what is happening here. And we as academicians, we expanded the definition and added 2 additional categories. Very early, where it was diagnosed from the 1st to the 9th month, and late, between 6 and 12 months after delivery. So it's a vast expanse, and I will tell you why within a couple of slides. The incidence is very wide. They attribute it to socio-economic conditions. I really doubt it. But it has been reported that it happens in 1 in 4,000 in live births in US. So with my SSG hospital, when I was there, it might occur once a year. And in Nigeria, 1 case per 100 means if it was once again SSG hospital, we would expect around 35 cases, means every 15 days 1. That's peripartum cardiomyopathy. Don't think it has happened to someone else. It will not happen to me. It has some very characteristic feature. Don't worry. You can see this picture, whose characteristic feature is a politician, typical Indian politician. In the same way, peripartum cardiomyopathy also has this characteristic feature. Left ventricular systolic dysfunction. So the problem starts with the SO node and an ejection fraction less than 45% with or without left ventricular dilatation. But then what is the problem? The problem is that the presentation is very non-specific. Very non-specific. It can happen to anyone at any time. So for us to suspect, therefore I congratulate Dr. Sneha to keep this topic. Makes you sensitive that yes, and when you listen to it again and again, say like endometriosis, when we were undergraduates or even postgraduates, Dr. Jagruti will bear with me. How many cases of endometriosis we had seen? Hardly. We went on listening to lectures and all, whatever, there are many other reasons as well, genetic and so many others. But now, I am sure Jagruti, if I am seeing at least 1 case per week, Jagruti must be seeing much more. So therefore, we require to attend these sessions. And therefore, congratulations, Dr. Sneha, for having this academic orientation, even in so much traveling. Congratulations. The presentation is very non-specific. Dyspnea, anyone can have. Fatigue. Every pregnant woman complains of fatigue. Cough, even upper respiratory infection can be cough. Orthopnea, that should make you very alert. Paroxysmal nocturnal dyspnea, pedal edema and hemolysis. All these can happen in countless other conditions we know, and therefore we are taken off guard. And it doesn't stop here. Its problems are not only in a very non-specific, very quizzical presentation. It has many tails. As you can see here, this animal has so many tails. This condition has so many tails. Although the recovery of heart function occurs in 45 to 50% of cases, a long-term mortality years after a PPCM can be as high as 20%. Permanently leaves an injury behind. Though many patients may recover depending on their left ventricular ejection fraction at the time of diagnosis, that is a latest report, therefore I said new things have come, 2025 report, the condition is still associated with many adverse outcomes. And the dreadful adverse outcomes I will enumerate: brain injury, cardiopulmonary arrest, pulmonary edema, and death. So mortality is high, PPCM can be bad, and then you will ask me as a teacher, sir, in that case, why does it happen? We don't know. We as academicians, as students of science, don't know. But it happens for sure. Because we don't know the exact reason, we come out with many theories, and that is understandable. My bet is on autoimmune conditions. Nutritional deficiencies, wait, 2030-31, we will get the result. The hemodynamic stress of pregnancy which others could handle, and her heart suddenly gives way. Suddenly gives way. A hormonally mediated vascular insult. On this, I have just reviewed a paper. I cannot give you further details, but that is an excellent paper coming from England. I have just reviewed it for the European journal, and no further details, but these things are now going to come up. So be prepared, and once that is ready, practitioners like Sarfaraz Bhai will be looking for solutions, and then it will be easy. Once we know the cause, we'll give you the solutions very easy. Risk factors, yes. Clear risk factors are now clear, very clear. Age elder than 30 years. Surprisingly, all of you who are doing obstetrics, and I'd love to do obstetrics, I still get down at 2:30, get up from my bed, get down 2 flights of stairs and conduct delivery. I live in the same campus, complex, though I have another house somewhere else. Here only, at 2:30 in the morning, I still go. I love obstetrics. And these days, age more than 30 in the mothers, pregnant mothers, young patients, is a rule. Currently, of all my booked patients, only 2 or 3 are less than 30. All of others are 30 and 31 and beyond. 40, 42, thanks to IVF also. African descent, that is where people are studying a lot. Nothing to do with poverty or anything. African descent, pregnancy with multiple gestation, where the heart, load on the heart is understandable, just gives way. Prior concurrent preeclampsia, eclampsia, and that is making us very much aware regarding the probable autoimmune cause. Maternal cocaine abuse, thankfully we are not seeing. Oral tocolytic therapy, unjustifiably used for a very long time. Please, we all know that tocolytics more than 15 days, even more than 48 hours are not effective. But then people go on giving it probably from one pregnancy to the other, and parity more than or equal to 4. Why did I bring the Lord and Master? We always require, our psychology is such that we require a Lord and Master to fix up things for us. And our Lord and Master here, I have fixed up the criteria. The European Society of Cardiology for Pregnant Mothers has fixed up a criteria. Not an European Society for Obstetrics and Gynecology. 3 criteria. Don't go into the others. Development of heart failure towards the end of pregnancy. Absence of any other identifiable cause. Left ventricular systolic dysfunction. Left ventricle may or may not be dilated. Later on in prognosis, it will help. Primary diagnostic tool ECG and echocardiogram. Nothing else. ECG findings can be non-specific. It is for your, so therefore get a good physician. Good, excellent physician in your team. Don't beat around the bush, because you will not be able to pick up a non-specific STD or T-wave abnormalities. They can. Chest radiography findings consistent with cardiomegaly and pulmonary edema. And further cardiovascular testing can be done by cardiac magnet MRI. To complete the list, and as soon as physicians step in, all these lists will be there. But you will require a team effort, ask for help. We continuously ask for help. Just day before yesterday, for a TLH, I had to ask my dear friend, and Jagruti is also dear friend, once again our classmate, Dr. Sandhya, to spare her nitrous oxide. The reason being this was not fitting in. So there she runs in. So we always ask for help and create a big and excellent team. And why excellent teams make champions? Why is it that we won this? It was because consistently all throughout the tournament, we had an excellent team effort. Management needs teamwork. For you and me to know, this is in your and mind control. We know something about this, that these are pregnancy safe agents. Dietary sodium restriction, loop diuretics, beta blockers, hydralazine or nitrates. Now we are comfortable with both, more with hydralazine and digoxin. You will require your physician friend. This is the list. They know how to manage arrhythmia. Anticoagulation therapy remains controversial. Mechanical support, they will come in. Shifting to ICU, investigational therapies, I have put a mark there. I'll be covering it 2025 advances I'll bring in. And in very ill patients with hemodynamic instability, inotropes might be necessary. So you can see the team. You require an ICU man, an anesthetist, your cardiologist, an ECG person, imaging person, so many things. I was giving a lecture in Rome. And the topic was shoulders first. I am reminded this. The answer comes here. It is applicable. The shoulders first, prolonged obstructed labor with a jammed head. I presented everything on the video and everything. It was a world conference specific to high-risk obstetrics. And a full house. And my German professor friend, who still continues to be a friend, got up and asked me, Professor, this is an excellent method. Though we are not recommending its use right away because we require all the clearances and this and that, let them handle it. But you tell me, what advice should we give or what we should tell the anesthetist when we are doing this? And that point comes to all of you now. The answer which I gave. I told him, Professor, our job is not to advise the anesthetist. Our job is to get the best anesthetist for doing this job. In the same way, your job is not to interfere with your physician friend, your intensivist and all those people. Don't get panicky. The team is here and I have told you the reasons, the etiology. This is not because of your negligence. This is not because of you. Her autoimmune condition crashes. Her vascular heart system crashes. It's her business. Not because of, we'll do the best. We will fight. But let them do their work. Something new which has come up, and that is bromocriptine is being now targeted, and intravenous IV globulin is being worked on. Pentoxifylline, a comparatively recent entrant, and even the certain like co-transporters too, like SGL2 and all, are besides the other which I have told you. Of your interest is handling labor. It is our headache. All up till now was their headache. This is our headache. The primary goal of delivery management is to reduce the seriousness of maternal and fetal complications with delivery as clinically indicated. Once she is hemodynamically unstable, that should not, you don't touch. What about cesarean section? Cesarean section is not indicated for this condition. Yes, if there is an obstetric indication, don't hesitate. Get a fine team, take it to a hospital where there are all facilities and do it. People like us finish cesarean sections, even Thadwala is here, Prakash Bhai has just left, Hirani sir, masters. We can finish it in 20 minutes. How much time the cesarean section takes? But only if there is an obstetric indication. What about lactation? Most medications used in treatment of PPCM are considered safe for lactation. Don't worry. Give what they are giving right now. Due to benefits of breastfeeding, many authorities recommend breastfeeding to able women who are able to do so. Friends, something latest. You know this man. This is the latest picture. If you don't know, you are not reading. You are only reading politics. This is Subhanshu Shukla. He is currently upstairs. He is watching us from there. He is our man in the space. The same way something latest has come in this, and that is an implantable cardioverter defibrillator. This helps, and nice papers are there even in pregnancy. Not big report, hardly 12, 15 cases from somewhere where ICD helped and the patient came out very successfully. The last part of the lecture, prognosis. I am not going into the differential diagnosis and all, no time. But for you, more important is what will make this patient fine, better. Small diastolic dimension, left ventricular diastolic dimension, LVEF, ejection fraction more than 35%, be happy. Absence of troponin elevation, absence of an LV thrombus and a non-African American entity. This you ask specifically. Today you attended. Thank you, Dr. Sneha. Tell Sneha madam, thank you. And ask your physician, what is the LV dimension? And he will be shocked. They consider obstetricians as, something. Ask them. And then thank me silently. Poor prognostic factor, dimension more than 6 centimeters, LVEF less than 35%. You will also understand. QRS more than 120, and this I will be putting on my website. You can go and copy there. Complications. Wasn't this enough? If there is a complication, you will feel Asman se gira or Khajur mein atka. You come out of PPCM and then still complications. You have every reason to cry. Thromboembolism is a dreaded complication. Arrhythmias remain for a longer time. Recurrent heart failure. Cardiogenic, she comes out and again goes in failure. Comes out. I have seen this, therefore I am telling you. Comes out and again goes in failure. Cardiogenic shock. And to the fetus, fetal distress from hypoxia. And that is bad because you will have to seizure that out. Death occurs. Yes, it will occur. It occurs in 7 to 15% of subjects globally. It leaves its effects long term. About 50% patients will improve. 50% will improve. But 25% develop chronic heart failure and the remainder die during the course of the disease. So not a bad condition. And it doesn't stop at one. You have seen this film. Bar bar dekho. Recurrence is common. Bar bar dekho PPCM. Chances in subsequent pregnancies is high. Patients should be advised against further pregnancies and monitored closely across the board if you can. But somehow they don't believe in us and they want another pregnancy. If at all a pregnancy is desired, it should wait for at least 5 years after the ejection fraction has normalized. 5 years after the ejection fraction has normalized, there is no big data. No big data. This is based on anecdotal papers. This recommendation which I brought is based on anecdotal papers. I am sorry for that. You can't expect a big data on this, on such a condition. Once in lifetime and you had it, you will not forget it. So friends, today's condition was like this. Like this film. A very serious film. But people have met with successes. I have seen just 2 years before I was called by one of my students practicing in the city. Sir, come, rush down. I rushed down. It was a PPCM. And I saw, and she survived and survived well. Why? Because the entire team worked. And when the entire team plays its role well, then you got nominated for Oscar. And then, friends, you can expect a healthy mother in possession of a healthy baby. Thank you, Dr. Sneha. Wish you all the best. May God bless you.
Excellent presentation, sir, with wonderful images. Dr. Gopal Hirani, sir, please. Dr. Gopal Hirani, sir.
if Hirani sir is here.
Yeah, thank you, Dr. Pankaj, for your excellent and insightful talk and presentation, as usual, and unique way of presentation on the topic of PPCM. You have broken down a complex and often a high pressure scenario into a clear, structured, and practical approach. Your experience and clinical wisdom was seen throughout your lecture, and I'm sure everyone in the audience is taking home not just knowledge, but also confidence to handle such situations more skillfully. So we appreciate you have taken out time, and we look forward to learning more and more from you in future sessions as well. And I remember
If
you talking in the
these words
same way.
coming from anyone else would have been nice. God is kind to me. But coming from someone like Jagruti, like Sandhya, more so, with whom we have wept, with whom we have laughed, with whom we have eaten, with whom we have beaten. Thank you. I feel very overwhelmed. Today I will eat one common extra today for dinner. Is common. It already I got the message that it is served. Thank you.
Yes.
God bless you.
Pankaj, I have a question if you can answer.
Yes, I will try to answer. I will
Yeah,
surely try.
Pankaj, I wanted to know, since you are handling some of the elderly pregnancies also, is there the incidence increased of peripartum cardiomyopathies in these cases compared to the younger patients?
No,
Because with ART and all.
No. There is a direct pure PPCM. No data on that. I have clearly identified the four or five high risk factors. Their grand multiplicity is not coming in. I understand, and even elderly prime is not yet. There must not be enough data. Nimish bhai, there is one. You are also very keen reader and researcher and pioneers in situation in IVF and all. So you must have read like mad, and you must still be reading because reading is addictive. I'm sure you will understand that not much is coming in literature on this data because it is not a very common condition.
Yes, true, very true.
But once it happens, you had it.
Oh, it's a nightmare.
And all are sending me messages of thanks. That is what a teacher is supposed to do. And thank you, Sneha madam, for bringing in for once a rare condition. It really helps. Thank you so much, and God bless you. And may your dreams crystallize. I am sure my dear friend Uday will pardon me. I will not be able to stay. I will go hungry. And all three of my children are here, so I would like to join.
Yeah, but sir, I would like to thank you from the bottom of my heart, because majority of the obstetrician, it's a nightmare for them. The moment you feel that everything is fine, and all of a sudden the patient collapses or becomes breathless. You have thrown the light on this condition in such a practical way. I'm sure everybody is going to thank me. Thank
Dr.
you.
Kirti,
Not only me.
Dr. Kirti has made a point.
Yes.
And see, I'm getting the inputs.
Yes.
Keep it in your mind. Your eyes will see what your mind knows. That is not the breathlessness. Oh, pregnancy, progesterone related, it will happen. No. Is she going in for PPCM? So, Kirti, you are right. Very valuable input. Your eyes will see what your mind knows. Excellent. Thank you, Sneha madam. God bless you.
Thank you, sir. Before you leave, sir, we'll have a word from Dr. Gopal Hirani, sir, and Jigna ma'am.
I had heard him last in Japan. We had met last in Japan, and then it's a good fortune to meet him.
Though we are all mesmerized, sir, with the talk and not able to come out of it, but Gopal sir, your words, please.
One of the finest human beings I have ever seen, Gopal bhai.
Yes, Gopal sir, please.
You are visible.
Yeah.
Sir, you are visible. Please speak, sir. You are unmute as well. I think he's having some network.
Dr. Jigna ma'am is also there. Jigna ma'am?
Sort of Jigna ma'am and Gopal sir's word, and then we move for the next session. Dr. Uday sir is already here.
Yeah, Jigna ma'am is there.
Yeah, it was very nice, and PPCM is and sir has represented it very nicely, and it is always nice to hear from sir. Every time it gives new messages and new take homes are there always with sir. So thanks a lot very much, Pankaj Desai sir.
Yes, Gopal bhai, we can see him.
Yeah, Gopal sir, you can speak, sir. A few words of closing from you, sir. I think he's not able to listen to what.
Gopal sir, can you hear us? Gopal sir?
I'm just calling him. Till then, we can continue with the next one.
Yes, please. Thank you.
Is it
Thank you,
okay?
everyone. Thank you.
Nice to listen to you, Pankaj, and very difficult to speak after you have already spoken. Quite a challenge it is, but very lovely topic, and you covered it very well. Thank you so much. Wonderful listening.
Yes.
Yeah,
Yes,
sir,
yes.
Parag sir, sir, would you like to say something? Parag sir is also here.
Pankaj, it was
Yeah, in
fantastic.
fact, I have invited
Listening to you
Parag.
is
Yeah.
a treat always. And we just heard you a couple of months ago, and Uday, I totally agree with you. In Pune 2 months ago, we were giving back-to-back oration. My only question to POJS was, am I speaking after Pankaj Desai? If so, I'm not speaking. No, but they were very kind, so they had me first, and then we had Pankaj's oration because you can't match his oratory skills. Thank you,
Parag sir,
Pankaj, for being here.
Thank you, sir. So we'll move
Yeah,
on.
so I think we welcome Parag, and Parag is not only the ICOG chairperson at present, but also the national coordinator of AMOGS, and he has come today as our guest. So I would request Parag to speak few words for
Thank you. Sneha, I don't want to interrupt the wonderful scientific session. Uday is waiting here to deliver his presentation. I'm sure it will be as good as it is. And I'm happy that the AMOGS committee led by you is crossing boundaries. And today you are interacting with so many stalwarts from Gujarat. So I really appreciate your efforts because, exchange of knowledge is something which is really important in these days. My best wishes for the program and best wishes to you for the forthcoming election. Uday, I'm not coming in your way to
Yeah.
your
Thank you so
presentation.
much. In fact, we are also eager to listen to Dr. Uday. Please go ahead. We are
Always a
happy.
pleasure, Parag, that you are there. It's always a pleasure to see you and meet you. So thank you so much for being there.
Yeah.
And so with that, if you permit me, I'll share my screen or
just a minute. Archana ma'am, please
Sure.
introduce.
Yeah.
We have got eminent faculties from Gujarat itself. Dr. Kokila Desai, who is president of Surat OB Society. Dr. Deepa, who is currently the president of Baroda Obstetric and Gynec Society. And Dr. Rajiv Vyas sir from Surat. I think we'll just straight away move to the talk. Any of the chairpersons, Kokila ma'am and Deepa, both of you, I can see can introduce sir, and we are eager to listen from him right now.
Yes. Good evening, everyone. It's a pleasure to introduce Dr. Uday Thanawala, sir. He's a consultant obstetrician and gynecologist at Navi Mumbai. Chairman ICOG in 21-22, the Vice President Foxy in 2015, Treasurer of the PCOS Society of India, Chairperson Medical Disorders of Pregnancy Committee of Foxy in 2006 to 8. He is the founder, secretary, and past president of Navi Mumbai. He was the joint secretary of Foxy in 2005.
Thank you.
And he has a lot of other credits to his career. He has the GM Masani Prize for the best research paper in 81-82 and the Dr. Datta Award for best journal publication of Foxy in 2005. So without taking much time, we are eager to hear about VT from you, sir. Over to you. The stage is all yours.
Thank you so much for that nice kind introduction, and I would like to share my screen. Now, what we are talking about in BET is what we people are mainly concerned is the obstetric problems and recurrent pregnancy loss, and venous thromboembolism is a part of the things when we use heparin, or we use an anticoagulant for thromboprophylaxis. So Sarfaraz had told me the topic is thromboprophylaxis. So I'm concentrating more on the use of heparin for the recurrent pregnancy loss, and if you have VT, what all one does. So yes. So let's talk about rational use of thromboprophylaxis in obstetrics. So these are a few clinical scenarios. After 8 consecutive miscarriages, patient A has a recurrent miscarriage screening. All her blood tests return normal. She inquires about what medication to use in subsequent pregnancy. So will you use heparin in this particular case? Patient B presents with a positive pregnancy test. She has had 2 DVTs in the past 7 years. Will you use heparin in this particular case? Patient C is pregnant for the first time. Her sister is positive for APS and has aspirin and heparin treatment after 4 pregnancy losses. So is this patient, does she require thromboprophylaxis? Patient D is diagnosed with APS and has 3 miscarriages. She is now 5.3 weeks. Does she require heparin now? And a 6 week duration in postpartum for patient E, who is heterozygous for factor V latent. So start thinking about these clinical cases and let us see out of these cases which actually does require thromboprophylaxis. So the first cases who had 8 consecutive miscarriages, but all her investigations for APL, etc., were normal. No, she does not require, by the literature, by the book, she does not require heparin in this particular case. Patient B presents with a positive pregnancy case. She has had 2 DVTs. Now she had 2 venous embolic thrombotic episodes. So yes, she 100% does require thromboprophylaxis here. Patient C is pregnant for the first time. Sister is positive for APS and 4 pregnancy losses, and she had a successful pregnancy after aspirin and heparin, but it doesn't mean that she has also got APL. So unless you investigate her and prove something, and it is not familial when they have this, so basically she does not require thromboprophylaxis. Patient D is diagnosed with APS and has 3 miscarriages. Now she's 5.3 weeks. So yes, certainly this patient will require thromboprophylaxis, and a 6 weeks duration in a postpartum patient. We were just talking about postpartum myopathy, but a patient he who's heterozygous for factor V laden, yes, she will require thromboprophylaxis. So let's go a little deeper into this and let us look at RPL basically. A patient with the previous 3 abortions, when you are meeting a patient with multiple abortions, what do you answer when she tells you that what are my chances of having a normal child after 3 spontaneous abortions? So, basically, I think the first thing which we have to do, and it's a very important component of tender loving care. Sometimes we can't do anything about these cases, but what you need to tell them is, for them it is a bleak future. 3 abortions, I mean, they say abhi to chauthi baar kaise hoga, kya hoga. So it is, you have to tell them these statistics that after 1 spontaneous abortion, the chances of having a repeat abortion is just 15%. After 2 consecutive abortions, it rises to 25 to 30%. But even after 3 consecutive abortions, the chances that she'll abort again is maximum 33 to 45%. For a woman who has had a live birth, even if she has a multiple losses in her risk in future is just 30%. So if she has a live birth and in 30%, so the chances are not very high. उनको बोलो आवाज कम करो. Just tell them. So basically, after investigation, the contributing factor can be identified in 40 to 50% of the time. When treated, the prognosis for a successful pregnancy outcome is typically 80%. Even in couples where no underlying problem is found, the chances for a successful pregnancy can be typically in the range of 50 to 70%. So the idea of telling you all this is that first we have to tell the woman that everything is not too bad. And when you investigate whether the causes is anatomical factors are there or not there, genetic factors are there or not there, autoimmune is there or not, the infection or endocrine screen, basically you are still left with 40 to 50% which fall in the group of unexplained pregnancy losses. And that is the thing. Now, the question comes, in these cases, do we start an empirical anticoagulant therapy based on this history. So basically, there are a lot of studies which say no, it is not supposed to be done. We have the SPIN study, the ALIFE study, that there's no benefit of low dose aspirin or combined low molecular weight heparin in cases of unexplained RPL. And I'll come to a little bit towards the end of my presentation, because we will talk about the ground realities and exactly what more research has shown about this. So, of course, the definition of recurrent pregnancy loss, there's been no consensus has been reached on the definition of recurrent pregnancy loss, which can be defined as repetitive loss of clinical pregnancies, either consecutive or not. And thrombophilias is what we are talking about today. So you have acquired group, the antiphospholipid antibody syndrome. The inherited thrombophilias like the activated protein C resistance, factor V latent mutant, prothrombin gene mutation, protein S deficiency, protein C deficiency, antithrombin 3 deficiency, hyperhomocystinemia, and homozygous methyl tetrahydrofolate reductase deficiency. These are all the inherited thrombophilias which we are dealing with. When you talk about antiphospholipid antibody syndrome, what all do you have to diagnose a APLS syndrome? You need to have either a history of vascular thrombosis, or you need to have a pregnancy morbidity. And in the pregnancy morbidity, you should have either 3 or more unexplained consecutive miscarriages with anatomical, genetic, or hormonal causes excluded, 1 or more unexplained deaths of a morphological normal fetus at or after 10 weeks of gestation, 1 or more premature births of a morphologically normal neonate at or before the 34th week of gestation associated with severe preeclampsia or placental insufficiency. And what is the laboratory criteria? When you have such a patient, you want to investigate them to prove that whether she's got APLA or not. The things which we do is the IgG and IgM of anticardiolipin antibody. We do the lupus coagulation. That is, either we do the activated partial prothrombin time, kaolin clotting time, or the dilute Russell vapor venom time. And what is now also done is the anti-beta 2 glycoprotein 1 IgG IgA. So these all 3 criteria laboratory tests are done. And if you have either of these history of vascular thrombosis or a fetal morbidity with 1 immunological criteria of either lupus anticoagulant or the other things positive, beta 2 glycoprotein, or the DRVTT positive, then you label that patient as having the APLS syndrome. Now, so basically screening is recommended after 2 pregnancy losses. This is what we are generally doing now. Let's come to a clinical situation. A gravida 5 comes at 6 weeks of pregnancy, first missed abortion at 9 weeks, second chemical pregnancy, third ectopic pregnancy. We did a HSG, cavity was normal and the right tube was normal, and at fourth she had a missed abortion where the karyotype was normal. Now technically it's basically 2 abortions, because ectopic and chemical pregnancy are not considered as repeated losses. But we got a DRVVT positive, the lupus anticoagulant positive, and the antiphospholipid antibodies bind to trophoblast, exaggerate the complement activity, stimulate inflammatory cells, and cause injury to the developing uteroplacental unit, and possibly resulting from thrombosis. And that is the reason anticoagulant therapy will help these patients. So in women with recurrent miscarriage associated with antiphospholipid antibodies, the live birth rate in pregnancy with no pharmacological intervention has been reported as low as 10%. But when you treat it, the success rate is very good, almost 70 to 80%. And there is good, so this is what is known as obstetric APS syndrome. So when you treat this syndrome, it helps. So even if they don't have a vascular event or a vascular deep vein thrombosis event, but if they fall into the group of those pregnancy losses plus any of those APLA blood tests positive, then it is a must to start them on aspirin and heparin. And when you start the aspirin and heparin therapy, it is basically started as soon as the pregnancy test is positive or as soon as pregnancy is confirmed. The rationale for the use of heparin is that this drug, apart from its anticoagulant action, seems to promote successful implantation in early pregnancy. So many of the IVF clinics now have started giving them heparin in an event to get positive pregnancy results, especially in cases who have, it helps only in cases where APLA is positive or any of these tests comes positive. In generally, it is not recommended, but many people are empirically doing it. The explanation for this may be that heparin binds APL and thus prevents APL, reducing the psychological coverage of trophoblastic cells with a potent anticoagulant protein NXA5, but it remains to be established. What is the dose? What are the advantages? When do you start? When do you stop? Low molecular weight heparin and aspirin grape had 84% viable infants compared to 16% which miscarried. Now, if you start unfractionated heparin, is it okay? Yes, because more or less the results are the same. It is cheaper, but you have to take multiple injections in a day, and both are equally effective when low molecular weight heparin and unfractionated heparin. So both can be offered to the women depending on what they can afford. Many of our patients may not be able to afford low molecular weight heparin. They can be put on unfractionated heparin. So basically, what we use is enoxaparin and dalteparin, and unfractionated heparin. The dose of enoxaparin is 40 milligram per day subcutaneous. The unfractionated heparin is 5,000 units twice daily in the first trimester, 7,500 units twice daily in the second trimester, 10,000 units twice daily in the third trimester. So that's how we give this thing. But when the patient has had a vascular event also and she has got APLA positive, then you have to start enoxaparin in the dose of 1 milligram per kilogram subcutaneous every 12 hours, or dalteparin 200 international units per kilogram subcutaneous daily. An unfractionated heparin, if you are giving this particular patient, subcutaneous dose of 12 or 8 hourly interval, so as to obtain a PPT 2 times the patient's normal. So basically, you need to monitor these patients more strictly. In fact, that is why most of us have switched over to using a low molecular weight heparin and not unfractionated heparin, because monitoring is very easy. You don't have to monitor anything in low molecular weight heparin. But when you're using unfractionated heparin, you may have to do repeated APTT to monitor the intensity of anticoagulation. What are the side effects of heparin? Bone loss, thrombocytopenia, which can be immediate type or late onset, but in general, we hardly ever see so many side effects of heparin. And when do we stop heparin and aspirin? Electively stopping low molecular weight heparin 24 hours before planned induction of labor is sufficient. Electively stopping prophylactic dose of low molecular weight heparin or unfractionated heparin at about 38 weeks of gestation, and if you are looking at spontaneous labor, so one can switch over from unfractionated heparin to low molecular weight heparin to unfractionated heparin, because the action, the duration of action is very less. So as soon as she goes into labor, you can stop it. But in general, most of us, when we are doing it for APLA and bad obstetric history, around 36, 37 weeks, we just would want to stop the aspirin and heparin and then plan a delivery of these patients. And let's talk about inherent thrombophilias, because this is one field which there is not much of a clarity. There's a strong association between second trimester miscarriage and inherent thrombophilias like factor V laden, factor 2 gene mutation, and protein S deficiency. So when you have unexplained second trimester losses, we have these patients with suddenly in the 5th month, in spite of sonography showing a good cervical length, the next week they have rupture of membranes and they just abort. So those are the patients. In fact, I have done the screening for inherent thrombophilias, and to my surprise, I've found many of them having this protein S deficiency present. And when they were treated with aspirin and heparin in the next pregnancy, they've had successful pregnancies. But this is personal experience about inherent thrombophilias. Let me also tell you that it is easy to say that women with second trimester miscarriage should be screened for inherent thrombophilias like factor V laden, protein S, and protein C. But that cost is $15,000. So how many of your patients can actually afford that to be done? But it may be worthwhile in patients with bad obstetric history. So basically, this is where we stand on inherited thrombophilias, because basically we must remember that factor V laden is very rare in Asia, but protein S deficiency, which I was talking about, is a vitamin K dependent anticoagulant protein that is activated by protein C to ultimately decrease the conversion of prothrombin to thrombin. So basically, this is, and of course, the test is better, more reliable when it's in a non-pregnant state. But these are tests which are there. One, if patient can afford it, yes. And if it comes positive, you may get a positive result by starting anticoagulant and all. I'm not talking too much about the other thing. So when you come to the ASHRAE guidelines, basically they say that for women with RPL, screening is not recommended for hereditary thrombophilia. So there you are in 2022 guidelines say, because there is no clear-cut treatment. They say that they're not sure if aspirin and heparin would definitely help these patients. So basically, testing for thrombophilias, it is basically all these other protein S, protein C, and antithrombin deficiencies. Basically, is still a very vague concept. But one must keep it in mind that if a patient can afford it, do those 2 or 3 basic protein C, protein S, and factor V Leiden, if you get something positive, maybe it is worth putting them on aspirin and heparin, though technically they say that it really does not help because one prospective randomized trial, the live birth rate for women treated with an enoxaparin was 86% compared with 29% taking only aspirin. So the heparin therapy, according to this paper, during pregnancy may improve the live birth rate of women with second trimester miscarriage associated with inherent thrombophilias. There is insufficient evidence to evaluate the effect of heparin in pregnancy to prevent a miscarriage in women with recurrent first trimester miscarriage associated with inherent thrombophilia. So what I'm trying to say is inherited thrombophilias, second trimester losses, yes, you may think of aspirin and heparin, though not as yet proven. But in the first trimester abortions, inherent thrombophilias will not play a role. So if you have a patient with 3 first trimester abortions, do not do that whole inherent thrombophilia screening and all. But those patients are the ones where APLA, if positive, heparin and aspirin will definitely help. So let's do some practical things when you come to it. The 36-year-old woman, multipara, presents in early labor at 5 a.m. She's got a history of DVT at 28 weeks of pregnancy and is on therapeutic doses of low molecular weight heparin. The last dose was given at 8 p.m. last evening. The current gestation is 35 weeks and her previous 2 deliveries were both induced for post-maturity. Cervix is effaced but not diluted. She demands an epidural. So what are you going to do? Are you going to check the APTT levels, and if normal, she can have an epidural? Yes, if you want to do it, you will have to check the APTT levels. Advise her that she is fine. She can have it after 8 a.m. if she labors. No, because she's on a therapeutic dose. Though 12 hours have passed from the last dose at 8 a.m., but she's on a therapeutic dose. So we'll have to wait for 24 hours before we give her an epidural technically. Advise her that it would not be safe to insert an epidural catheter under 24 hours the last dose, so not to inject any more and admit her and observe her. Now, she's a patient who has been post-dated the first time. Right now, cervix is not open. So this is possibly correct because we will just observe her for the next 24 hours. And if she's not in labor, we can observe and wait and see whether she requires an epidural or no after the 24 hours of the last dose pass. Admit her and change to unfractionated heparin. Yes, one can do that. Advise her to have no further heparin till after delivery to reduce the risk of bleeding. You cannot do that because this patient, if she's not in labor, she may again have a thrombotic event. So one cannot do that. So this is how one has to rationalize the use of heparin and put it into clinical practice. The American College of Chest Physicians said that women with a history of antiphospholipid antibodies and a previous history of pregnancy loss, it is recommended to use prophylactic dosing of anticoagulation. Whereas though with the inherent thrombophilia and previous history of pregnancy loss, it is less clear-cut if anticoagulation should be recommended. For women with thrombophilia and a history of late fetal loss or stillbirth, placental abruption, or fetal growth delay, the use of anticoagulant should be reviewed on a case-to-case basis with no clear-cut recommendations for its use. So basically, what do? We have a patient with 3 spontaneous abortions or 3-4 pregnancy losses. Do you empirically start aspirin and heparin and see what happens? Many of the people have tried that, in the context of unexplained RPL, low molecular weight heparin, and is prescribed in up to half the patients despite of not being supported by current guidelines. The guidelines say no. If test results are normal, do not start heparin. But basically, of all the effects, It has been started in many patients, and many patients, not only us who sometimes do it in clinical practice, many things do it. But here is a study which has said in 2020 that unexplained recurrent pregnancy loss, the spontaneous loss of 3 or more consecutive pregnancies without an identifiable risk factor, is a big challenge, like we all know. It is now being used to true, though there's no significant improvement in late pregnancy complications in women which are treated. But this was a very interesting meta-analysis, and this is the last slide which I have got, published in 2024, where they actually analyzed more than 1,000 patients, and they've even stratified it, how many pregnancy losses, what dose of heparin, what was the weight of the patients and all, and a different heterogeneity of patients, and all the subclasses, etc. They ultimately came to the conclusion that our meta-analysis, however, does not support the use of low molecular weight heparin in any subgroup of the women with unexplained RPL. And the important thing is that the study did not include any thrombotic condition, either acquired or congenital. So they had screened these women. It was only the empirical use of heparin which they were starting. So they have a very clear-cut conclusion here that just empirical heparin and aspirin does not help. It does not show any benefit if your patient doesn't have a thrombotic condition, which we tested for. Thank you so much for this opportunity, Sneha. Very nice of you to invite me there for this, and I hope I didn't take too much time.
In fact, yes, definitely we would invite the comments from chairperson, but I would like to make some comments. Sir, I have heard you speaking on this subject now, I think many a times. I can't say how many, 5, 6 times at least, but definitely for every time you have improvised it practically, that is what I would say. And definitely you have discussed all the aspects, what clinical scenarios we face in day-to-day practice. So I'm very happy that those who are attending this session will be greatly benefited.
Thank you so much, Sneha. Thank you. It's always your goodwill which keeps me. I can never refuse, even though it's my OPD time. I can never refuse you. So it's great to have you, and wish you all the best for your future endeavors. And thank you so much, Sarfaraz, and all the others who are here. Thank you for having me here.
Thank you for your precious time as well. Thank you, sir. Do we have some comments from Dr. Deepa? Yes.
Yes, ma'am. Right, sir, it was an excellent rendition. The clarity with which you have given the advantages of whether to start empirically and when to start therapeutically is really very important nowadays, because as you said, we can't just irrationally start giving or keep giving both heparin and aspirin to patients. So the newer guidelines which you stated, the meta-analysis which you presented, have given us a very clear insight, sir. An excellent talk for such a topic, sir. Thank you so much.
Thank you so much, Deepa. Thank you.
We can have a word from Dr. Kokila ma'am also. She was there.
Is she there? Dr. Kokila Desai, President Surat.
She was there.
I can't see her. Yeah.
Thank you, sir, for the insight. Thank you so much.
Thank you. Thank you so much. And please excuse me. I have to leave now. Thank you very much.
Thank you. Thank you.
Thank you,
Thank you. Absolutely excellent presentation. Now, Saiti.
Yeah, we can go ahead with the next session.
Saiti.
Yeah. It's okay. We can start with the panel now. Because you can call. It's okay.
Yeah, ma'am. You start with the experts and operators. Yeah.
Yeah, so should I directly start?
I have to introduce the experts.
Yeah. So
yeah, we have Dr. Amita Shah, madam, as an expert available with
yes.
us.
So
discussion is on medical emergencies in obstetrics, case-based discussion.
Yeah.
For the moderator, and we have two extreme experts with us. Dr. Bharti ma'am. Bharti Maheshwari.
I doubt whether she's joined. Dr. Amita Shah.
Amita ma'am did join, I could see her. Yes, she's here, madam. She's here. She's past president Baroda Obstetric and Gynec Society and has been a practitioner with us, quite senior faculty from Baroda. And we have esteemed panelists. Kazi, you can just call everybody on the platform and madam can start.
Yeah. First panelist, Dr. Harish Shah, my teacher, under whom I have learned how to do oncology practice and how to do for them surgery. Welcome, Dr. Harish Shah. Another panelist, Dr. Sonia Golani, ma'am. She's also from the Baroda and she's a senior consultant at Bahilal Amin General Hospital. Welcome, ma'am.
Yeah, welcome, Dr. Sonia. Welcome, Amita, madam. Welcome, Dr. Harish Shah. Yes.
Past secretary of Nadiyad Society and right now the president of Nadiyad. Right now the secretary of the Nadiyad Society. Monica Singh, ma'am. Welcome, ma'am. Dr. Svetambari Patil, ma'am. She is the associate professor of ND Desai Medical College, Nadiyad. Welcome, Svetambari, ma'am. Dr. Saral Bhatia is there from Surat, Department of OBGYN, Government Medical College professor. Ruta is in emergency. She will join later on. She is the secretary of Surat. Dr. Kuresa Kuresi, ma'am. She is here since beginning. Welcome, ma'am. She is right now the IVF specialist at the, I think, Indira IVF Center at Valsad. Dr. Karthike is also there since the beginning. He is the secretary of Rajkot Society. Dr. Sagar Thakkar, secretary of Gandhidham Society. Dr. Jubin Thakkar from Aanand. Dr. Prakash Parmar from Rajkot and Dr. Jay Lakhani from the Porbandar. We welcoming you all on this special academic feast by Dr. Sneha. Ma'am.
Yes, thank you so much, Dr. Kazi, for that, that hard work, all the hard work for bringing everybody together. So thank you so much. And I would once again welcome all my panelists. And without much ado, we would like to go ahead with the discussion, because we have been all the time discussing the obstetric emergencies, but yes, there are some situations where, while managing the obstetric emergencies, suddenly we face some different kind of emergencies. So I would just like to ask Dr. Harish Shah, are these medical emergencies are on a rise? And if so, what is the reason for this? What do you all feel about it? Dr.
Yeah, good evening, madam, and all the faculties as well as all the organizers for this wonderful webinar.
Good evening,
hello.
Sir. Yes.
Hello.
Yes.
Am I audible?
Yeah, sir.
Yeah.
Yes.
It's definitely in rise. There are certain reasons. We can say a modern lifestyle or socio-economic concern, etc. Number one is the base time for parturition is around 20 to 25 years of age. Now, most of the time, as we see in urban area, especially working women, high socio-economic, highly educated women, usually marriage is delayed beyond 30 years of age. The first conception is maybe between 35 years of age. Second conception may be beyond 40 years of age also. Apart from that, there is a lot of stress, workload, impact, physiological changes which is occurring in third decade of life. Then there are high incidence of infertility leading to IVF conception, and all IVF conception definitely have high risk pregnancies, majority of them, maybe multifetal pregnancy, etc. And with increased rise in the ratio, incidences or delivery by cesarean section, and we all know that second time when patient is having repeat pregnancy following cesarean, there are the pregnancy becomes a little high risk, as well as there is possibility of placenta previa, sometimes adherent placenta, and etc.
Right. So you're very right that, the women are becoming career minded, and that's a very reason the age of marriage is also getting delayed. As you rightly pointed out, the work stress, the changing eating habits, the lifestyle, which is sedentary lifestyle, And in addition to all this, the smoking, alcohol, and the substance abuse, all these factors, all in all add together, result into obesity, and then the resultant infertility, ART and IV procedure, resulting multifetal pregnancy, and of course the decreased tolerance, or I would say, reduced threshold for pain also has led into, rising cesarean section and increased operative intervention, that leading to placental complications. So definitely it's not only the obstetric emergencies, but medical emergencies, they are on a rise because of the comorbidities which are associated with this age, which is an advanced age. So we now go ahead with the actual case scenarios. Here we have the first case where you have this 36-year-old lady who is conceived with IUI. Her husband stays in Dubai and she stays in a village. So, she is registered with the obstetrician, coming for follow-up regularly, but suddenly she's lost to follow-up, and at 34 weeks, she reports to a primary health care center in the village with complaint of upper abdominal pain and pedal edema. So her BP that time was 176 by 116, proteinuria was present. And because the BP was so high, only tablet nifedipine retard was given by the medical officer, and she was referred to the higher center. Unfortunately, she did not get admitted to the higher center for next 2 days. And then when she got admitted, the BP was again 168 by 110 in spite of tablet nifedipine retard. So they added tablet labetalol and magnesium sulfate to her. Because you know that a sub-district hospital has the facilities for cesarean section, anesthesia, etc. They just went ahead with cesarean section, delivered a female child, 1.8 kg, and her blood pressure was constantly same. So Dr. Sonia, this patient was having suddenly severe cough, breathlessness around 20 hours after the operative procedure. Her pulse rate was high and BP was very high, 220 by 118. Suddenly her oxygen saturation dropped down to 70%. Her chest was full of wheeze and all adventitious sounds, no clear breath sound. What do you feel? What is your differential diagnosis, and how would you manage this patient?
So this patient, who is a known case of hypertension with a sudden onset, suggests that there is a medical emergency, and going by the tachycardia, BP and the low oxygen, we will probably think of a case of she has developed pulmonary edema. The differential diagnosis for these could actually be any other cardiac problem. It could be cardiomyopathy, she may have developed. It could be some cardiac failure due to a left ventricular dysfunction. Could be even sometimes maybe a cardiac arrhythmia. You could also think of sepsis leading to these problems. So the difference.
So definitely cardiac emergencies. Yes, I accepted. Pulmonary edema and peripartum cardiomyopathy. You just heard Dr.
Yes.
about it. Yes. So any cardiac problem, definitely agreed. So how would you manage this patient now?
So as I am working in a multi-specialty setup, I have the advantage or the facility to call. So basically it will be a multi-specialty approach. It's not me who is going to manage. So
but then suppose you are in a private small nursing home and this happens in front of you, how would you manage?
So one is that if you see a patient like this, one is you do the ABCD, check the airway, breathing, circulation, and whatever drugs you feel like. If I feel that she has pulmonary edema, I would immediately give her Lasix. Try to control the hypertension at the earliest. And
what is your drug of choice here?
I will labetalol, probably will give that. And then whatever basic investigations, like maybe a chest X-ray, if possible, a blood gas will definitely help us. And
yeah, so because it is a catastrophe, you will make her propped up, you will give her 100%
oxygen,
TMG, and as you said, labetalol, but provided you have the best of opportunity, NTG infusion will be a better because she got pulmonary edema. So by the time you try, to resuscitate this patient and manage her, so you also want to know, because you're not sure of the diagnosis, so you go ahead with all these investigation, ECG, X-ray. Yes. Now you want to give her nebulizer also, because you want to make the, the maybe bronchospasm, some sort of, it may be relieved of that.
Yeah.
Now this patient has received all this what you said, but suddenly she went into, by the time your anesthetist came, she went into cardiac arrest. Now how do you manage her?
So basically shift her to a higher center because you're at a place where you'll
But
not
she's in a cardiac arrest, no, at present, Sonia. So we have to manage her.
Yeah,
at
you
least
have to resuscitate. Yeah.
Right.
So you put her on, give her CPR basically.
Right.
With the team and try to put her on a ventilator.
Right.
If you can, and then do all the resuscitation and try to get her oxygen and pulse back.
Correct. So that is what you said is absolutely fine. Dr. Karthikeyan, do we have Dr. Karthikeyan Shastri here?
Yes, madam.
Yes. So Dr. Karthikeyan, this patient was now successfully resuscitated by the anesthetist and the intensivist. So maybe after an hour or so, she came on spontaneous respiration. Blood pressure is now recordable 100/64, and she improved later. The question is, what went wrong for this patient? She was a regular registered patient initially up to 24 weeks. Was it preventable? What went wrong? Can we have some inputs from you right from the beginning?
Madam, pre-eclampsia and eclampsia being very notorious, especially with the fluids, we need to be very restricted with the fluids, and good use of diuretics would have and quick control of her blood pressure, which continuously maintained was 180 around, which is not good. With injectable labetalol and diuretics, the patient should be managed well post-operatively so that the BP gets
But
stabilized.
then we are talking about already when the patient has got severe hypertension. Now this patient, considering her as high risk patient, when she comes to you, can we screen her right from early pregnancy? Can we screen her? Can we give her some preventive medication? Can we restrict her or rather reduce the incidence of severe hypertension?
Madam, if first 24 weeks, if the patient was antenatally visiting regularly, the prediction of hypertensive disorder in pregnancy can help with started of ecosprin, prophylactic started of ecosprin 150 milligram HS with regular follow-up. Second trimester ophthalmic artery ultrasound Doppler can also help in predicting the upcoming event of preeclampsia.
Right.
And also.
Yeah. So anybody wants to add? Madam Qureshi? Yes, Dr. Prakash?
Ma'am, we gynecologists don't want to make anything, means we don't want to make expense to the patients. Day by day, I am receiving many complicated patients in many ICUs in Rajkot. I want to share one case. Within 1 week, I have operated a same case of severe preeclampsia, 29 week, 30 week of pregnancy managed by gynecologists in some periphery. And the patient landed up with severe hypertension, IUFD, abruption, AKI, DIC, and when she has been reported having a hypertension, even though the gynecologists are giving them only antihypertensive and calling the patients on the routine interval. If we are suspecting that this patient is having a suspected for a hypertension, we should not follow the routine antenatal care. We have to call the patient very frequently. We have to call the patient every 15 days, 20 days, or a weekly. You have to monitor the protein urea. And why we want to pull on the pregnancy when the protein urea is more than 3+ or 4+, when there are the signs are there. If you terminate the pregnancy timely, then there are not multi-system failure and you can save the patients. Okay. Second thing I want to convey is that when you know that this patient might landed up in a complication like this, then why should one operate such kind of patient in a single specialty unit?
Right.
You have a medical colleges at everywhere nowadays in India. If you don't have enough premises, physician is not in your premises, then refer the patient to the medical college or a trust hospital where the multi-speciality setup, or either you bring the patient to one of the ICUs, operate the patient there. There should be a backup facility there. We are not telling that admit the patient in ICU, but if the facility or a single visit of a physician or intensivist might be there, then we can prevent such kind of complications, because suddenly patient's SpO2 is everything is fine, and now within a few hours, patient SpO2 has been 17. So the timeline of the event is not when you are in a court of law, you cannot prove yourself that this is the timeline which can be easily digested.
Yes, I would like to add to this. See, both of you, Dr. Karthike and Dr. Prakash, I know you are, I hope you remember I have come to
Yes, ma'am. Yes, ma'am.
And we have discussed so many cases that time also. So, managing these patients when it becomes complicated, that also has to be have very, very definite timeline, as you said correctly. But I would still go much earlier. All of you have to notice that she's 36-year-old. So she's an elderly gravida, treated for infertility, conceived with IUI. So gamete manipulation also is there. So all this, put her on very high risk of HDP gestosis score. Okay, so when she is at a high risk of HDP gestosis, she should be screened at 11 to 13 weeks for NT scan, uterine artery pulsatility index, and then she should be given the prophylaxis of low dose aspirin and high dose calcium. Two things. And then such patients should never be told that everything is fine. She has to be informed that considering all your risk factors, you are at high risk and you will need more frequent visits. So if at all you miss, your pregnancy will become complicated. That is the first thing. Secondly, when you diagnose such a severe hypertension, you don't have to take it, so lightly. Even at PHC, if you remember, her first blood pressure was 176 by 116. So that time she was given tablet nifedipine retard, which is a very mild, slow-acting antihypertensive. So that time either IV labetalol or oral capsule nifedipine 10 milligram, that should have been given. I'm sure it is equally effective if you compare this. So at PHC, you cannot give IV labetalol, but you can definitely give capsule nifedipine 10 milligram orally. Let me clarify, orally, not sublingually. Okay, so that was the second mistake. And third, when she comes to sub-district hospital, as Dr. Prakash rightly said, just because you have a OT anesthetic and facility for cesarean section, you should not take up such patient for cesarean section at SDH. She has to be managed by a multidisciplinary team, and she has to go to the tertiary care center, as rightly pointed out, to the medical college. Okay, because this patient, right from pre-operative, you need to give restricted IV fluids, what we give it as preload. When you deliver the baby, IV methergine should never be given. In fact, it should be carbetocin or the oxytocin concentrated infusion. And the moment you remove the baby, you can definitely start her on IV Lasix. So that is how, and this patient needs to be monitored for first 72 hours in a SDU or ICU setup. Definitely. So such kind of things with catastrophe will be preventable. So definitely this was a preventable catastrophe, and right from early pregnancy, mistakes on our part has made the patient land up into this catastrophe. So that is a discussion for this case. I'm sure we are having lots of learning together. We go ahead with the second case now. Dr. Qureshi, Madam Qureshi, this is a case for you. We have this multi-para admitted to emergency ward at 11 p.m. and as a obstructed labor, multi-para, previous vaginal delivery. She was admitted as a obstructed labor. Pulse rate was 110 and her blood pressure was 130/80, but the mother was exhausted, liquor was meconium-state, and so with antibiotic prophylaxis and fluid resuscitation, she was taken up for cesarean section. In top, it was quite uneventful except a small extension of the incision, and that was repaired well. There was no significant blood loss in top or immediate post-op. She was shifted to ward as a routine, and after 1 hour, she became confused, drowsy, vomiting tendency developed, and her blood pressure was only 80. Pulse was rapid and thready. Madam, when you examined, there was no pallor, no signs of hemorrhage outside also or internal, and uterus was well contracted. What do you feel is the diagnosis, and how would you go ahead with that?
After the examination, we can know the patient is being soft, but it is not hemorrhagic because the uterus is well contracted. There is no sign of hemorrhage, but patient is confused with tachycardia. Definitely, we will shift her in ICU. probable diagnosis will be the embolism. It may be pulmonary embolism. It may be embolism. There may be some cardiogenic reason. So first we will shift her into the ICU. We will start for ABC.
Right.
Urgently, we will send her all investigation. We will involve our intensivists as well as physician for all these, and we will start fluid also. And
yeah. What my question to you is, madam?
The reason of hypotension.
Yeah. What my question to you is, you know that definitely it is some non-hemorrhagic shock, and you have all these lists. But by the time you call for help and your anesthetist or intensivist comes for your help, you have to resuscitate her. So you go for aggressive fluid resuscitation. But
yes,
do you do any bedside investigations to come to the
yes.
diagnosis?
Immediately we will send her blood reports. We will go do bedside X-ray also. We will do ABG.
Yeah.
Urgently, because we are having all these facilities in our ICU, so urgently we send for ABG also.
Madam, but that will take time, no, madam. ABG will take lots of time, even the X-ray and all this.
We will start for this hypertension. We will start vasopressin also.
We go to, yeah, okay, madam.
Yeah.
You have discussed the initial part, the diagnosis part very well. Dr.
Yeah.
Sati Bhatia, can we have the further clarification on this? What bedside test?
I think we have to rule as the patient general condition suggestive of there is no pallor and there is no hemorrhagic shock. Then we have to rule out other condition which can lead to shock, like neurogenic shock. It may be due to hypoglycemia. So the basic investigation will be complete blood count. We can go for urine routine micro or specific examination, and we can go for random blood sugar, as we have to rule out there may be hypoglycemic shock or whatever may be the random blood sugar we have to go.
Okay.
And then if the time permits, then we can evaluate the later on. And
okay. So, doctor, yeah. So, see, these are the bedside tests done. So, bedside hemoglobin by the SARIS method, it was done. Hemoglobin 10.8. Blood sugar was done by the glucometer. So, that was 550. Urine sugar with the dipsticks was urine 4 plus, and ketones were 3 plus. Now, what is the diagnosis, and how would you go ahead with the management?
So, as per investigation, I think the diagnosis will be ketoacidosis. It's a complication of diabetes. That is over diabetes mellitus. It's a grave emergency, and the patient will be immediately shifted to ICU. We have to take help of physician, and as early as possible, we have to manage the hyper or diabetic ketoacidosis.
Right.
Usually, the first is we have to resuscitate the woman. We have this maybe I think due to osmotic diuresis, the patient land up in hypotension.
Right.
So first step is to we have to correct the intravascular volume compartment.
Perfect.
Okay. Second, then we have to, due to diabetic ketoacidosis, the drug of choice is insulin. It can be given as a bolus dose, or we can start infusion of insulin. But in this condition, we have to take the help of physician as early as possible, because other than help of intensivist and physician, it is difficult to manage diabetic ketoacidosis.
You're very right. Basically, you should have that, at least you should know that if you have a blood sugar of 550, giving 10 to 15 units of insulin slowly as initial bolus, in fact, improves the patient very fast. By the time your physician reaches there, he can advise you that much. He can just advise you. You will not do the further management, but initial dosage of the insulin is very, very important, and correction of the fluid deficit is very important. So aggressive fluid resuscitation, you can see here, this is written in the help of the physician or intensivist, that initially you have to give hypertonic saline of first 2 hours and then come back to normal saline and 250 ml per hour. That is our physician friend's job, that we are not concerned, but diagnosing it in time and going ahead with the bedside investigation, that is most important, because If you have bleeding for an obstetrician, well and good, you can do something. But if you don't have bleeding and your patient is worsening in front of your eyes, that is the worst thing that can happen. So coming to a correct diagnosis at the earliest with the help of bedside investigations. In fact, that is what is the message from this case I want to deliver. Secondly, now the question remains whether this episode was also preventable. I don't want to discuss how you come to the correction of the acid-base balance and electrolyte balance. That is none of our business. We have intensivists to manage that. But can this, could this have been prevented? That is a question.
Definitely, madam.
Definitely.
Nowadays, it is mandatory to detect diabetic in all ANC patients.
Yes.
We can
So that is called as
go for
screening.
DIPSI method or any other methods available
Right.
to rule out whether it is overt diabetes or GDM, whatever present in pregnancy. And if we detect earlier in pregnancy, we can easily manage pregnancy and labor.
So just for the benefit of our house, can you just say which test you should do for universal screening and when you should do?
DIPSI method. We are doing screening method as DIPSI method.
So how do you do that? How do you do that?
We have 75 gram of glucose, irrespective of status of her general condition, and then we have to measure the values after 2 hours, and if it is more than I think 145, then it can be considered. We have to evaluate for HbA1c or FBS, PP2BS, and if the value is more than 200, then it can be considered as overt diabetes.
Overt diabetes, correct. So anybody wants to add here for the screening?
We repeated in every trimester once again.
Yes, madam. I was about to invite you. I just thought maybe some panelists wants to invite. So, Madam Amita Shah, please go ahead for your expert comments. Yeah.
Yeah. Whatever is that, as we want to prevent this catastrophe, first trimester, it has to be done once the patient is visited. Repeatedly, we have to repeat in every trimester. That also will give a great lesson and clue for the further management.
Right. So basically, first visit itself. So you have the universal screening, that is screening for hyperglycemia for every woman during every pregnancy. That means first pregnancy, if she doesn't have or didn't have any hyperglycemia, it doesn't mean that second pregnancy she will not have. Every pregnancy, every woman during every pregnancy, she has to be screened with 75 gram of glucose, as you said. Whether she is or no, or irrespective of her timing or OGTT, that is called as single step 75 gram OGTT. And as you rightly pointed out, the 2 glucose sample, if it is showing more than 100, it is over diabetes. But there's one more category, that is if it is 120 to 139, that is called as gestational glucose impairment, GGI. And such patients also need the advice on diet, and they should be kept on high priority or observation. They should be screened later, of course, at 24 and to 28 weeks, and later in the third trimester also, as Amita Madam has pointed out. So thank you so much, all of you, for this discussion. We go ahead with the third case now, Dr. Prakash. This is a case for you. So we have this unregistered primary gravida, married for 2 years. She comes to you with 9 months amenorrhea, pain in abdomen, discharge per vagina, mild fever, breathlessness, cough, and she's got tachycardia since 3-4 days. There's no pedal edema, but she was having mild pains, and suddenly she developed spontaneous rupture of membrane. So you thought she's not progressing, so started her on augmentation, oxytocin infusion. Unfortunately, she landed up into fetal distress, so she has to be taken for cesarean section. So when the anesthetist examined, he found that there is a diastolic murmur. So she was given regional anesthesia, baby delivered, but suddenly she started becoming breathless. So what is this condition, Dr. Prakash, and how would you go ahead with the acute management first? We will talk about the active management first.
This is a nightmare for obstetrician.
Yeah.
Okay, that suddenly patient during cesarean section or after anesthesia, patient become breathless or SpO2 is getting down. One should think about everything: amniotic fluid embolism, high spinal, or maybe some cardiac factor. So in this patient, as patient is having a history of fever and breathlessness, tachycardia, unregistered patient might be have some pre-existing cardiac disease, might be she have. We have to immediately do chest up, or our anesthetist should be competent, and we should have an adequate staff to provide anesthetic.
Anesthetist has given you a clue that he's got a diastolic.
And then we have to immediately, if our vitals are not okay, and if anesthetist is considering that we have to intubate this patient, then immediately we have to intubate the patient, rapid closure of cesarean section safely, and after that, once we stabilize, we have to shift patient to the multidisciplinary approach or a take up help of cardiologist.
Right. So definitely, when you are thinking in terms of a cardiac disease, we have to see that she doesn't go into further worsen further. She is most probably landing up into cardiac failure, but then you have to see that she doesn't worsen, and all efforts to control for that. So this is actually a case of rheumatic heart disease, as the anesthetist has given us a clue. She's breathless even at just with routine activity. She was breathless. So class 3. And aggravating factor, she's got infection, fever, cough, tachycardia. She has labor pain. On top of that, she had spontaneous rupture of membrane that added to her infection. And then the augmentation with oxytocin definitely added fuel to the fire. So Dr. Zubin, we want to ask you, how do you classify the heart disease according to NYHA and etiology and, grades of severity? Dr. Zubin, do we have?
Yes, ma'am. So, based on NYHA classification, heart disease are classified based on their symptom, based on like 1 to 4, and depending on the grade of severity, whether the symptoms are present at rest or at mild activity as well. So NYHA grading is given by the New York Heart Association, and grade 3 or grade 4 are usually a grave symptom which should alert an obstetrician. And for even a grade 2 symptom, we should always have a physician consult and a well evaluated cardiology workup of the patient.
Right.
And also it can be classified based on etiology, as whether it is an acquired or a congenital disease like a rheumatic, or whether it is acyanotic, cyanotic, an ischemic disease, any underlying cardiomyopathy, and whether the pregnancy whether diagnosed early, then consult with the cardiologist whether there should be a continuation of pregnancy based on the proper diagnosis, and whether there is evidence of cyanosis in the patient as well.
Okay. So suppose, now this patient definitely she has dropped her oxygen saturation. So you do her propped up, give her oxygen, and then continuously monitoring diuretics, maybe digitalization as per the intensivist, mechanical ventilation if at all required. So all these things will be there. But suppose this patient had come to you before pregnancy. So how do you evaluate whether she has heart disease and whether she can, or whether she wants to, if she wants, whether she can conceive? How do you guide her?
Yes, so based on the classification which has been given by WHO and NYHA both, there are a few conditions where pregnancy itself or continuation of pregnancy or even having a pregnancy is contraindicated, like where the ejection fraction is less than 25%, or the patient is having an evident Eisenmenger syndrome, where even this a conception could be a life-threatening to the patient.
Yeah, there are
and
3,
also
4
if there is
conditions. There are 3, 4
Yes.
conditions which are congenital.
Yes.
What are they?
So whether there is a I think there is a valve replacement or a valve issue, or there is a cyanotic lesion, a large
There is
VSD, or
Eisenmenger syndrome, that is one, that is Eisenmenger vibration, Marfan syndrome, and coarctation with aortic root involvement,
aorta.
and primary pulmonary hypertension. These are the 4 conditions where actually you have to advise against pregnancy, absolutely no pregnancy. And of course, NYHA grade 3 and 4, you have to optimize the condition, cardiac condition before conception. Okay, so absolutely no pregnancy for some conditions, and optimize the lesions or the status, cardiac status, and then you conceive. Okay, so you have to actually
consider.
counsel them that what are the maternal and the fetal risk, what is the pregnancy outcome, the prognosis, and what are the social and cost consideration, because this is going to be a very high risk pregnancy, more frequent monitoring, more frequent investigations, and the stress on, we have to, the stress the patient and the family has to face, and of course the frequency of care. So Dr. Monica, we would like to hear from you. Dr. Monica Batra. Yeah, should this
Yes.
woman, suppose you get such patient during early pregnancy. Okay, so can you hear me, Dr. Monica?
Yes, ma'am.
Yes, yes. So suppose you have a high risk pregnancy. Just now, Dr. Zubin has told us these are the 4 conditions where the woman should be advised against pregnancy. Unfortunately, you find that this lady has got maybe one of these conditions, maybe Eisenmengerization, and she comes to you that unfortunately, doctor, I mean, she won't say unfortunately, but she would say, now, doctor, maybe that I have conceived already, though you advise against it. Can I please continue this pregnancy? So what would be your advice?
As per WHO modified criteria for maternal cardiovascular risk, if a patient is coming in class 3 or class 4, we have to say that if they are in class 4, they cannot continue pregnancy. It's better, it's ideal to terminate the pregnancy in the first trimester. It's best to remove it in early first trimester, that is before 8 weeks. Because the physiological changes in pregnancy, whatever occur, it's better to remove the pregnancy before the physiology in the pregnant lady starts occurring.
Right,
So,
right. So
the class 4 conditions like you already said that Eisenmenger, coaptation, Marfan's, and that primary
primary pulmonary. Yeah. So all these conditions, don't think that maybe this poor lady has conceived. So, maybe just let us try our best, hope for the best. Nothing of that sort, because these are the conditions which is a risk to the mother's life. And that is why we are not allowed to do that. And we have to advise against pregnancy. But if at all she conceives, pregnancy termination during very early first trimester, that is before 8 weeks, as you rightly said. Suction evacuation is the preferred choice, and MTP, beyond 12 weeks definitely would carry much risk, and that's the reason we are not supposed to allow this pregnancy to go beyond this. So Dr. Shwetambari, we want to know from you how frequently, suppose you have this patient with cardiac disease, and now she is optimized, but how frequently you want to ask her or advise her for ANC checkup or ANC visits?
Hello, good afternoon, ma'am. Good evening.
Good.
I think this patient has missed her condition, which could be congenital condition, mild, or NYHA grade 1 or 2 during first trimester. And unfortunately, she got missed during her ANC period as she progressed to grade 3. So ANC care is very much important in each and every patient, and we have to be very vigilant for first visit. So do we give a detailed history of any of her syncopal attacks or any history of venous thrombosis or palpitations, recurrent palpitations, or history of cyanosis, and any breathlessness during exertion we have to take. Then also antenatal in first visit we have to take care of any family history of such patients, congenital heart disease or any other family history or any operating history in the patient.
Yeah, suppose everything is fine. Everything is fine. You feel that okay, she's NYHA class 1 or 2. You have allowed her to become pregnant. So how frequently you want to come her for ANC checkup? Because routinely you advise, once in a month is okay. For her, what do you advise?
ANC care should be more frequent. Maybe every 15 days for at least 30 to 30 weeks, 32 weeks.
Yeah, okay.
And 30 to 32 weeks, there is a much more chances of going into cardiac failure, then much follow-up. Maybe weekly follow-up after 30 weeks is important. So we have to educate the patient and relatives for the signs and symptoms of worsening. So patient can come to the facility whenever it is needed. And we have to include the cardiologist also, as she is the diagnosed case of heart disease. So multidisciplinary approach with fetal monitoring. As the time of preterm delivery is also high.
Yeah. So any special advice you want to give to this lady? Any special advice you want to give about the rest, diet, salt intake, etc.?
Restricted salt intake should be there, 4 to 6 grams per day. And then it's already physiological changes of pregnancy going on in the body. So we do not want to increase her intravascular volume. So restricted salt, then consider good hygiene, especially dental care. Then adequate rest and normal physical activity is okay, but avoid undue exertion.
Okay.
And
What
correction
about the SAB prophylaxis, the benzathine prophylaxis? What do you think about it?
According to recent guidelines, it is not needed for each and every patient unless and she is going in some dental procedure or patient is low immunity, recurrent infections are there, then we can advise the patient.
Okay.
But otherwise, at the onset of labor, we can administer amoxicillin injectable. It's sufficient.
Right. So, Dr. Sagar Thakkar, we want to know from you, Dr. Sagar. Do we have Dr. Sagar? No, I don't think so. Anybody can take up this question. Should you ask her to come during labor or should you hospitalize this lady? And how do you decide when to hospitalize according to the grades of the disease? So I think Dr. Shwetambari, if you want to continue, you can go ahead.
Okay. As this is a known case of cardiac disease, if it is not non-symptomatic, we have to ask to terminate the pregnancy around, or we have to induce the patient, or elective induction should be planned for NYHA grade 1 and 2.
Okay, okay. Okay.
8 weeks. And we have to advise to come electively before labor.
Yeah. Sonia, do you want to add to this? Which class of patients, when do you want to hospitalize?
So NYHA 1, probably you will hospitalize them about 2 to 3 weeks before the due date.
Right.
For NYHA 2, around 30 weeks or so. And the other 3 and 4, as soon as whenever the patient comes to you, you have to admit and stabilize this patient for 3 and 4.
Right.
And you have to decide for the what medication she is taking, whether you have to change, put her on heparin or change the anticoagulation that she is taking. So all those things have to be decided. So you need to admit these patients.
Yeah, and even for the benzathine, you may
Yes,
have to advise them. Maybe at any point of time you feel that it's only NYHA 1 or 2, but you find that she's worsening, her symptoms are worsening. So
you have to tell, you have to inform the patient at any time there is any deterioration, she should report immediately, irrespective of whether you have called her after 2 weeks or 1 week.
Correct. So now that you have managed this, monitor this pregnancy successfully, you are approaching the term. When do you deliver such patient? Dr. Jai Lakhani? Dr. Jai?
Yes, ma'am.
Yeah. So we want to hear from you, Dr. Jai, whether you would like to allow this patient to go into spontaneous labor or you would like to induce her. And if at all, then how?
Madam, induction is only for, it's only for obstetric. Induction is only for obstetric indication. And in these cases, misoprostol tablet, there is a theoretical risk of coronary vasospasm and arrhythmia. Yes. So the preferred route.
Basically, our message should be very, very clear that absolutely no indication for induction just because she's got heart disease. So heart disease per se is not at all an indication for early induction. In fact, more the natural labor pains, more the natural delivery is the better, right? So if at all she has certain obstetric indications like maybe fetal growth restriction or maybe some worsening of the Doppler parameters, you feel that she is inducible, cervix is good, biceps is good, then you can induce, but that is for that indication, obstetric indication, as you rightly said. Now, if at all you induce her for obstetric indication, then what are the ways you would prefer for this patient?
Yes, madam. Misoprostol, as I said, misoprostol tablet is there is risk of coronary vasospasm and arrhythmia. So the route will be using higher concentration of oxytocin in less fluid, because we have to make fluid restriction as well in cardiac patient.
Right.
And cervical catheterization can also be done.
Right.
And if the dinoprostone gel, Serviprim gel is, if using, it should be used with caution, because if it is injected blindly in the vagina and if it goes in the myometrium, then there is risk of profound hypotension. So oxytocin and cervical catheterization will be a better route.
Better choice. Correct. So you're right. I think we are very clear on our views of the induction only with if at all right, only with oxytocin. If unripe, then go ahead with mechanical ripening measures like Foley's catheter, and then of course the Serviprime jelly. Okay. So Dr. Haresh Shah, we want to know.
I would like to add that pain relief is also important.
Very important. Yes, we are coming to that. We are still on induction, so we'll come to that. So what are the prognostic factors for such patients? Poor prognostic factors. What can worsen the patient? Dr. Haresh Shah? I think he was there initially. So I think Dr. Saral Bhatia, you can take up this question. What are the poor prognostic factors for such patients?
I think, madam, we have already discussed patient like primary pulmonary hypertension, Eiser-Marfan syndrome, or correction of aorta or Marfan syndrome, or severe rheumatic mitral stenosis with mitral valve less than 2 centimeters. These are having into high risk pregnancy with a higher mortality rate. So we have to be very cautious, and we have to take precaution while delivering this patient, and we have to also be very cautious in first postpartum 7 days, because there are more chances of any complication can
Perfect.
Yes, and imagine ICU for first 7 days at least.
Yes. So during labor, 24 hours later, and 1 week later, maybe within that first week, these are the times where the chances for heart failure are maximum. So definitely, for I think we have given sum up this case. I would like to say that if it is very high risk, a strict no for pregnancy, even if by mistake she conceives, go for termination during early first trimester. Now, when you have optimized the cardiac status, allow her to go for pregnancy, but you have to warn them, explain them what will be the prognosis, how will be the social and economic, condition, whether they are ready for frequent visits and all the monitoring necessary. That needs to be explained to them beforehand. And then, of course, smoothly, if you can sell through, then you have to allow her for spontaneous natural labor and delivery. That is the best. If at all there are some obstetric indications or complications to go ahead with induction, then of course you have to go with a safer measures like concentrated infusion of oxytocin. If unripe cervix, then Foley's catheter. So I think that is a very good message we have given. Now we come to, should we stop here or should we go ahead? Do we have adequate time? Panelists, it's your call. Should we go ahead with one case?
Yeah, finish it fast.
Yeah. So we have this 29-year-old para one delivered 5 days back, and I think we have had the talk also now. So
yes.
It's better that we discuss or revise it in short. She's complaining of dyspnea, fatigue since 2 days, and because the symptoms are significant, she comes to your hospital. So you find that she's dyspneic, hypoxic. So oxygen saturation is only 88%. So antenatally, she is, what risk factor she had is she was obese and hypertensive, but managed, controlled well on labetalol tablet. When you examine, she's febrile, pulse rate 90, BP 156 by 88. Respiratory rate now is 20 with oxygen, 2 liters of oxygen nasal cannula now, because the moment she came, she was the emergency. So first thing you do is put in an oxygen mask or catheter. So oxygen saturation is now 95% on oxygen 2 liters. And the chest, there are no adventitious sound. Heart rate is regular, S3 gallop is present. There is no edema, calf tenderness. So what investigations you want to do to confirm this diagnosis? You have managed this patient well, but what are the investigations to confirm the diagnosis?
So because she is 5 days post delivery, right? So as you said that the chest is clear and there is a gallop, so we first go into a cardiac problem. So most probably it could be a peripartum cardiomyopathy because she doesn't have any calf tenderness and pedal edema, so probably pulmonary embolizement DVT will be ruled out. So then the first thing to confirm the diagnosis at any setup will be not only doing the ECG and X-ray, but the blood test like pro-BNP. So that is the test which will probably stamp the diagnosis.
And even the D-dimer.
Yes, and the D-dimer test.
Right.
And such patients, as sir has given an excellent lecture, that immediately they have to be hospitalized. And the main treatment will be for a delivered patient will be diuretics, bromocriptine low dose, beta blockers to stabilize the heart, and probably digoxin also. As I said, it will be a multi-speciality. You have to involve the intensivist, cardiologist, and give the treatment accordingly.
Right. So basically, is it preventable? That is what is the question.
I think very difficult because the cause, we don't know what the cause is.
Yes.
And autoimmune concept of cardiomyopathy. So it's very difficult for us to predict as to which patient will land up into this problem.
Yes, so basically it is autoimmune, but yes, there are certain factors which are predisposing, as we said, obesity, hypertension, not well managed hypertension, so all these things. But definitely with healthy diet and active physical exercise, optimization of weight, optimum management of the hypertension, and as you rightly pointed out, diuretics and digoxin maybe whenever, but digoxin only when she develops it. But there is a role of prophylactic diuretics. So even NICE guidelines have come up with that, oral tablet Lasix given twice a day for 5 days. For any patient of hypertension, they say that you start her on tablet Lasix at least once a day for first 5 to 7 days, so that can, prevent her for going into PPCM. That is what, even as you heard it from sir, that bromocriptine is the drug which is at present, getting evaluated extensively. There are lots of studies going on, but because even today we say it is idiopathic, there is some role of prevention, as it is a healthy lifestyle and appropriate management of the whatever basic etiology or the underlying etiology she is suffering from. So very good control of hypertension, and of course the management and monitoring her throughout in ICU, maybe close observation, that is what is required. So that if at all we do that, I think we should be successful, though by the time we get a definitive management for, treatment of PPCM. So with this, I thank everybody. I would like to invite Madam Amita Shah for a comment, but I would just thank all the panelists for their, wonderful inputs and proactive participation. I would like to thank the entire Gujarat society, especially Baroda, Surat, Rajkot, Porbandar, Bhuj and Valsad, all these societies. And I would like to utilize this opportunity and make a humble appeal for myself that I'm Dr. Sneha Buyar and I'm contesting for the post of Vice President. All of you have seen me working for so many years. I've been working for Foxy since last 20 years and in various positions since last 10 years. So I request all of you to please vote and support me in my endeavor to make me as your representative. There are 2 posts for West Zone. So definitely you have one more choice in addition to me. Please do vote for me. That's a personal request from me. Thank you so much. Madam Amit.
Yes, Madam, Dr. Sneha, Madam, very rightly you said we have seen you last 2-3 years running from one corner to another corner of the country and managing so many successful webinars and seminars. And you have never told no to anybody, and you have crafted this panel discussion so nicely. Each question and each answer is so perfect that it is be taken as a complete guideline. I congratulate you And I really support you, and I wish everybody will come out with the flying colors in the next upcoming election. And I congratulate the organizers for conducting this webinar and nicely organized. Thank you very much.
Thank you, madam. Thank you so much. I have my dear friend, my batchmate, Dr. Sonia Golani also.
Yeah, all the best, Neha, all the best.
Thank you. Thank you, my dear.
Okay.
If you feel, all of you feel that I deserve, please do vote, and not only vote, please do canvas for me and, support me from your societies. Thank you so much.
Thank you. Thank you so
Thank
much.
you so much, everyone, for the wonderful discussion.
It was a wonderful discussion.
And I am also requesting all on behalf of Dr. Sneha ma'am, please support her on her candidature.
Thank you so much. Thank you, Dr. Sarfraz and Dr. Archana Dwivedi for taking all the efforts to coordinate for me. Thank
Voting
you.
line will be open from 1st of August to 10th of August
Yes.
for the Vice President, and for Chairperson after 16th of August to 25th of August.
Thank you so much. Thank you.
Wish you all the best, Dr. Sneha ma'am. Wish you all
Thank you, madam. Thank you so much. Thank you. I thank all the panelists, all the faculties, all the chairperson, and all the society members. Thank you so much. Thank you. Bye-bye. Bye. Bye, sir.